exciting new advances that were made in the targeted therapy field. So this is my exposure. Okay, so I'm going to talk about first landscape and traits of the fusion. Okay, yeah. Traits of the fusion driver genes in cancer overall, and then we're going to talk about the therapeutic opportunities that are present in this fusion driver gene. And then I realized in 30 minutes I cannot talk about all the non-NTRK fusions out there. So I'm going to just focus on my experience on those FGFR RAD and EGFR coming from the lung background. So, all right, so I classify them into current targets like ALK, RAD, ROS1, and NTRK. And then we have FGFR fusions as well added. And then there's emerging targets. So these are, there are already targeted therapies available through activating mutations, but then we find fusions that are as good of a target as the activating mutations. So that those are BRAF, EGFR, PDGFR fusion, NRG1 fusion. These are still in clinical trial realm, but we do have off-label drugs like afatinib that can target NRG1 fusion. And then there are current targets in liquid cancer like BCR-APRIL in CML and PML, RARA in AML, especially the N3 type. The fusion targets, we still need a good drug. It could be the fusion or the TIMPRESS or fusion in prostate cancer. So, what happens again? Okay. All right, let's have to look here. So for the landscape, so there's a nice paper that looked at all the TCGA data and figured out how many fusions are available in each cancer sample. And they came out with a median value of 1 fusion per cancer sample in TCGA data, but ranging from 0 to 60. The most recurrent sample type was the TIMPRESS prostate cancer, about 38%. And then FGFR3 TAC3 fusion was found in various tumor types, including the bladder, cervical, endocervical, lung squamous. And then other top recurrent fusions were the EML ALK4, and the RET and the FGFR2 fusions. So I would classify fusions as for diagnostic fusion versus pan-tumor present fusions. So the immune sarcoma fusion, as well as the Philadelphia chromosome fusion, BCR-ABL is a great example. There's one more, which is fibrolamellar carcinoma in the liver. It's characterized by the DNAJB1 and PRK-ACA fusion. But you have many more pan-tumor fusions, just like David said, and NTRK, and we think this is another emerging nice target that was found most frequently in the TCGA database. So, one trait about fusion is if the fusion happens with oncogene, like HER2, EGFR, RET, then you tend to see increased expression of those genes relative to the sample without those fusions across many different tumor types. And the RET and NTRK1 fusion found in thyroid cancer is a great example, as well as the ALK and the liver fusion that I told you. And if the fusion happens with the tumor suppressor gene, which is less frequent, then you would actually don't see much pattern. It's pretty inconsistent. However, there's some trend that shows that the expression of tumor suppressor gene is decreased compared to non-fusion samples. And the example is the recurrent CBFB MYH11 fusion that happens with acute myeloid leukemia. And the CBFB, which is a tumor suppressor, actually goes down in its expression. And what you see also in the whole TCGA database is that there are very few cases where fusion and activating mutations are present. So 6.4% have both mutation and fusions in the same driver genes, and 1.8 have driver fusions only. And when fusion events are present in a gene, same gene, the mutation in the same gene are rarely found. And if you just go after what's druggable, we find that there are potential druggable fusions found across as many as 29 cancer types. And these are the examples that you see here. This paper did focus on FGFR3 as the most potential drug target in many cancers, as many as 15 cancer types. What was interesting was the estrogen receptor gene, ESR fusion, was found not only in breast cancer, but as many as 16 different cancer in many different, 5 different cancer types. So in essence, it's really, these are prevalent across many different tumor types. And just a word on immunogenicity. So if fusion happens more like indel type, then there's less of a potential to become neoantigen, but if it's more like a frame shift, creates more structural changes, then it has higher potential to become tumor-specific neoantigen. But the overall trend is if you have fusion as a driver, you don't need many other occurring alterations. So there seems to be reduced mutational burden and neoantigen burden as well. So we generally think these are not good candidate for immunotherapy, and we maybe talked about the MSI case as well. But what was interesting was among these 3, there were better predicted neoantigen candidates with these specific ERG or RAD or FGFR3 fusions. And among them, the ERG fusions were thought to be immunogenic after doing the computational analysis. That remains to be seen. So now we'll talk more about the specific fusions. So FGFR fusion is important because it touches upon many different pathways such as PI3 kinase and the RAS and other apoptosis pathways. And there's 4 different types, 1 to 4, and there is different incidence of amplification, mutation, translocation happening in many different types of tumor. And those are cancer specific, the type specific as to what's more frequent, as you can see here. So I led the first FGFR. This was actually any actionable aberrations, including amplification, activating mutation, and fusion. And we used the agent AZ4547. This was a PAN, FGFR1 to 4 inhibitor at that time. And there was a subprotocol W as a part of the NCI match. So with other co-PIs, so we led this trial, and I just want to show how match was designed at that time, that you do the master screening, and according to the algorithm, you are matched to a targeted therapy of importance. And then once you progress, you do another additional biopsy to screen for another opportunity, and then you can go back to the master screening and then start on another agent. But if you don't find the target, and we actually enrolled 25% of these NCI match patients were rare tumors. And if you happen to meet that rare tumor indication and you don't have any other agents to go to, they were funneled into our other NCI SWAG trial, which is DART, dual anti-CTLA4 and PD-1 blockade for rare tumors. So they were getting nivolumab plus ipilimumab at that time. So we were married at that time, and after that we divorced. But so this was sort of the NCI, the main NCTN trial, and we were able to accrue patients across more than 1,000 sites across the United States. So our AZ4547 results comes from this platform of a grand basket trial at that time. So this is the patients who were enrolled and treated. It's interesting that they first got enrolled 70, and then we do all these analysis. It's really actionable, and I think we were actively accruing patients like 2016, 17, 18, and we were running into mutations or fusions we never seen before. This is like, as patients come, we're having like real-time assessment of whether this is a really good target or not, and then really amending the protocol real time when we find, well, the gastric amplification turns out to be a not good target, then we would amend the protocol, so that's not approved gastric cancer anymore. So it was more like a really like real-time enrollment thing. And these are the actual patients that got enrolled: invasive breast cancer, bladder cancer, cervical, endometrial, salivary gland. And the right side is the actual alterations we found. We have a lot of amplifications, but then we do have FGFR2 and 3 fusions, and then many different activation mutations we found. And this is the waterfall plot and swimmer's plot, and you can see that fusions as well as some activating mutations had shown nice response. Amplification did not. And here you can see that some of the fusions had a really nice prolonged response. So, overall, at the bottom you can see the whole cohort, arm W, had only response rate of 8%, but in the fusion arm we had response rate of 22% with a 6-month PFS of 56%. So it wasn't a trial that met its endpoint, but sort of showing the proof of concept that the fusion is a really good target. And subsequent NCI MAX trials, subsequent company trials have focused on fusion going forward. So currently, then, what do we have as therapeutic target? FDA approved. We have the infigratinib approved 2021. Previously treated unresectable, locally advanced, or metastatic cholangiocarcinoma, and all these 3 drugs. The next one is pemigatinib and then putibatinib. 3 drugs, all with same indication, and all with FGFR2. They focus on only 2, and they're only fusions, no mutations. They don't work well. And what's interesting, their sample size, the trial that led to approval was about 100, and then their response range is from 23 to 42%. Duration of response ranges from 5 months to 9.7 months. They're very similar drugs that are approved almost similar time period. What's interesting is putibatinib only tested their drug in intrahepatic cholangiocarcinoma, so that's the only difference in their FDA indication. And what's interesting among those 3, pemigatinib has a really interesting indication, which is relapsed or refractory myeloid lymphoid neoplasm with FGFR1. Here it's just one fusion. And they enrolled many different tumors: MPN, MDS, acute lymphoblastic leukemia, lymphoma, AML. And in this very small trial, 28 patients, they saw a complete cytogenetic response rate of 79%, which is amazing. And I didn't talk about the toxicity, but their toxicity were pretty similar to on-target toxicity, which is the hyperphosphatemia was seen, and the nail changes, diarrhea, all these other toxicities were seen. And then the next one, FGFR inhibitor that we targeted opportunity that we have is the erdafitinib. So what's interesting is April 2019 got accelerated approval. There was an NDJ paper that showed nice response rate and the duration of response. And then there's this confirmatory trial that led to regular FDA approval in January this year. And there's been a change in label here. So the initial label was FGFR2 and 3 with prior platinum-containing chemotherapy in urothelial carcinoma, metastatic locally advanced. But then, because the confirmatory trial had cohorts that had prior PD-1 or PD-L1 therapy, patient had to have received that before, and also the confirmatory trial, I looked at it again, was FGFR3 specific. So the approval, regular approval, is now just the FGFR3. As you can see, the PFS hazard ratio was 0.58, so pretty active agent, and this was the confirmatory trial presented at ASCO. Overall survival median 12 versus 7.8 months with hazard ratio of 0.6 difference for erdafitinib versus chemotherapy. And it did benefit all different subgroups. And then, as you can see, that there's a big difference in response rate of 45 versus 11 erdafitinib versus chemotherapy, with CR happening about 6.6%. And there's a very interesting paper in JAMA Network that showed if we were to use off-label erdafitinib in all solid tumors, what will be targeting? And they looked at the FGFR2 and 3, all the valid targets, mostly activating mutation as well as the fusions. They found that in many different tumor types, we can actually use these targeted therapy to target alterations such as fusions. All right, we'll move on to RET. So what therapeutic opportunities do we have in RET? The first, it started with selpercatinib. So accelerated approval 2020, and then regular approval happened in 2022. And it started with lung cancer and thyroid cancer. And it was the RET fusion in lung cancer that showed really good response rate. It's comparable to the NTRK story, at 84% with duration of response of 20% in treatment naive. And lo and behold, these are the people who progressed on chemotherapy. They even have better duration of response, 28 months, with response rate of 61%. And then in thyroid, in the same year that got the accelerated approval, in medullary thyroid, you target the patient, and then in the differentiated thyroid cancer, you target the RET fusion just as you do in non-small cell lung cancer. And what's interesting is they did go for pan-tumor indication, just like in the NTRK story. So in September 2020, this is really the all-solid tumor that has the same RET fusion, and it was a 41-patient trial. Other than non-small cell thyroid, which they already had indication for, and the response rate was 44%, duration of response, very similar to the lung and thyroid, which is 24.5 months. And it included pancreatic adenocarcinoma. So I had a patient with pancreatic cancer who responded really well, colorectal, salivary, unknown primary, breast, sarcoma, ovarian, intestinal, cholangio. So it is not common, less than 1% for sure, outside lung and thyroid, but you do have to look for it to give them opportunity. And it was pretty tolerable, but the common side effects are edema, diarrhea, fatigue. Pralsetinib is another drug available for RET fusion positive non-small cell lung cancer, and the response rate and the duration of response was pretty comparable, and they were both, the drug was both effective in treatment naive and treatment exposed group. And then the last but not least, EGFR, as you know, they have activating mutations. Classic is exon 19 and 21, and you have resistant mutation in exon 20. Now you have EGFR fusion with many different partners, but here, as you can see, this was a cancer discovery paper. I was one of the co-first authors because we kind of discovered the first few cases together, and we decided to make a team and publish it together with a preclinical scientist who kind of proved that fusion is a really good target. And these are the cases, case number 5 happened to be my patient, and really stage 4 lung cancer, and there was a time when we were doing NGS instead of PCR. We were kind of transitioning. Sounds very old, but and then they never seen EGFR Red 51 back then. So we were like, what do we do with it? Well, we have a lot in it. We didn't even have Tagrisso or sponsorinib. So we tried it, and then it, patient tolerated it well, and she's been more than close to 10 years out. ever since the diagnosis. She's still living well, asymptomatic. And most all the patients had PR here. And the bone was usually not a really good measure of the disease, so didn't really have PR for the last case, but a lot of them did really well. And these are the representative CT scans showing nice response. And it's the C-terminal EGFR gene portion that showed the fusion and connecting piece over there. And it's so rare that it's still not in any time, like I looked at it. But there's been case reports coming out, and a lot of them are just lung cancers, and they treated patients with all different types of TKI, even cetuximab, monoclonal antibody, and all showed nice response. EGFR SET14 fusion was found in colorectal cancer, and in that case report, they treated a patient with erlotinib, and there was a very good, significant durable response seen there. So fusions are rare, but if they happen in different tumor types, don't disregard it to say, oh, the EGFR is, it's important in lung cancer. No, you found it in other tumor types. It's likely to be still the driver gene, and so do what you can to get the drug and use it on the patient. So the take-home message here is there are many fusion genes across various cancer types, mostly strong drivers of cancer, providing a valid target for treatment. So fusion driver genes are currently offering therapeutic opportunities in the clinic. It's a current, it's not future, including both FDA-approved agents. There are many experimental, which are both clinical trials, like I told you, NCI match, but there are other company trials that are pan-tumors. And obviously, as a clinician, we always, if we can't get our hands on a drug, we try our best to get it off label. But it's been difficult recently. The more we publish, so that I think it's our job to publish even case report, case series, so that when you make a case to the pharmaceutical company or the insurance company, hey, there's actually a publication shows great benefit, and then they will rethink and sometimes give you the drug. So I think we're obliged to publish, and based on that, we should continue to design trial. And for the rare ones where pharmaceutical companies not that interested, I think we should talk to NCI and really in the foundations like SWAP, Hope Foundations, and just really design trials. Dr. Kurdrag and I really tried hard to do pan-tumor FGFR, and it was so hard. As you can see, to work with NCI and NCPN, there's a lot of hurdles, but you just have to be an advocate for patients and merge forces. There are still these driver genes, fusion driver genes are still being discovered as we speak. We are seeing, I didn't talk about partnering genes, like FGFR is important, but the partnering genes are still being discovered. We never seen this being fused with this gene, but the trend is whatever you partner with, a lot of times they're equally as potent. So I would emphasize that we still don't know much. And in fact, in clinic, what I am developing my expertise is what are the best computational algorithms out there to predict the computation, because it was never found and there's no preclinical model to say this is functional or not. Then what model best predicts its structural change and its functionality? So we're doing that in clinic because we're finding more fusions and activating mutations that were never described anywhere, not even C-bioportal anywhere. So, and then that are being investigated and therapeutically exploited. Please keep yourself posted regarding the progress, abstract and publication coming out. If you see something, go online and search for any kind of evidence that what you found is working. And if it's not, even if it's not working, if it's fusion, it's probably a potent driver. Except for some HER2, there are like bystander fusions that may happen, but most of them can be drivers. So I would use that as a therapeutic opportunity for patients. So we do save lives by applying these potent targeted therapy towards fusion patients. we like to encourage our patients. It's another model example of our patients getting targeted therapy and targeted immunotherapy, and we like to continue to encourage our patients. We're getting letters from patients like, are there many other patients alive as I am, and who are they? They're very interested. They want to be part of the support group, and we encourage our patients, giving them awards and just encourage their spirits to participate in trials, and that's how we make progress. So thank you for listening. And,
in the bladder world, EGFR is being looked at for non-muscle invasive disease, and like we know pretzels that sort of get inserted into the bladder and then release drug more slowly over time. I think you said for cholangio, it's sort of later line therapy, although we talked earlier about simpler genomes. Maybe they'd be folks are responding better in tumors where there's simpler genomes. Do you know if there's efforts to be moving them forward for cholangio or other places? Is that going to be like the general effort to try to? I mean, in the lung world, it's now you want that sequencing back ASAP because you know that if you have a targeted therapy option, that's the best way to go. But I feel like a lot of other tumor types, we're kind of reserving it for later on, and maybe that's not the right strategy.
I agree. I totally agree. And David talked about the earlier approach, like the neoadjuvant. I think not just lung cancer world, but in GI, every cancer world, we should be able to get the NGS, at least understand the whole landscape of the mutation and the tumor mutational burden, and even the heterogeneity, what's clonal, what's subclonal. That will give us a sort of comprehensive view, like do we think this is going to be aggressive, and because higher heterogeneity will lead to more resistant coming down the road. So yes, I'm a fervent proponent of doing NGS for every tumors upfront. Yeah, Dave.
This is not a question, but this is an actual how that pemigatinib approval got found. It was Dr. Vivek Subbiah in our group led a lot of the FGFR inhibitors. And literally, we have a faculty coffee area. He went to get coffee, and I think it was Servan Versavsek, who was in leukemia, came by, and they just started talking about FGFR. And Serdan was like, yeah, we have these rare tumors, leukemias, that have FGFR. He's like, yeah, I'm running a trial, phase 1. Why did I connect you to the company? Because the company was totally clueless about this area. And they connected, and that's what led eventually to that approval. It's just that conversation over coffee.
We need less Zoom meetings.
Yes, we need. That's the whole point. You need less Zoom meetings. You need to have more you got to encourage Northwestern to have more coffee bars for faculty.
I love it. Yeah.
And then I feel like you are the most successful physician that I know in getting drugs for people off label. and yes, as a community, we need to publish for sure. Any other tips? Just start early and be persistent.
Oh yeah, start early. So another tip is, I kind of assume 99% they will progress. So assume they're going to progress. So I get plan A, B, C, and then start working on papers. Get what you need, the tax information. All the denials up front, and then IV and PO are different. So you can work in parallel. So just get those things, and then definitely the waiting list for the trial is a must, but still off-label. Just get that, because it takes some people it's 2 weeks, some people it's like 4 months to get that ready paper. Yeah, so just think it early and getting prepared.
All right, thank you very much.